In 2004, she joined forces with Dr. Edith Orbis to develop a groundbreaking treatment protocol for patients with body image issues such as BDD and eating disorders. In 2005, Dr. Yip developed her own innovative treatment modality, integrating mindfulness, training, and strategic paradoxical techniques with CBT and the treatment of children and adolescents suffering from severe OCD, body image issues, and related anxiety disorders within the family system. She has published articles, presented her work at national and international conferences, and consulted on documentaries and major film productions on OCD in children and adolescents. Dr. Yip.
Thank you. Good morning, everyone. How are you this morning?
Good.
Awake? I want to first ask, how many of us here are parents today with children? So just about everyone here are parents today. Okay, all right. I can tell you that from my own personal experience, I had OCD as a child, and my parents, who are sitting right there, really didn't have any information about OCD, what it is, and what to do with me. One of the biggest problems is that anxiety disorders as a whole is often overlooked from school personnel as well as pediatricians, which is usually the first thing that you will do when your child has a problem. You take them to the pediatricians, and I can tell you that many pediatricians are not informed. And the goal of our talk today really is to disseminate information and to educate you about how OCD can oftentimes be overlooked or misdiagnosed, and how to correctly determine that it is OCD rather than one of the other typical childhood disorders. Okay? So I'm just going to give some brief stats. I don't know why this is. Because that thing is here. So I just want to give you some brief stats about OCD first before we go into the more specific details about Okay, so OCD can start at any time from childhood to adulthood, and it afflicts about 2% of the total population in the U.S., which is about 6 million people. Now, this number is an underestimate because, again, OCD is often misdiagnosed or underdiagnosed, and also consumers, such as yourselves, may not be aware that my child actually has OCD. How many of you had confusions about their diagnosis in the beginning? So I would say about 70% of everyone over here today. So this number is really an underestimate, okay? Now the big thing is that 33 to 50% of adults who have been diagnosed report that it started during childhood. And for me, I remember my first horrific images when I was 6. So it definitely starts during childhood, and if it's not treated during childhood, the condition just waxes and wanes and gets bigger, and it turns into a web of obsessions and compulsions. And the older the child gets that is untreated, the more difficult treatment becomes. So for the general adolescent population, OCD occurs in 1 out of every 200 school-aged children. This means that in the average elementary school, there are about 4 to 5 students with OCD in every elementary school. And I'm not so certain that teachers are going to be able to recognize that as OCD as well. So many children will experience almost all of the classic OCD symptoms by the end of adolescence. Males typically show more tic-like symptoms, whereas females show more of the phobic symptoms. This is a research study that was done at NIMH, and the graph basically depicts that the mean age of onset in children and adolescents with OCD is about 10 years of age. Males typically show earlier onset than females. However, gender differences disappear by adolescent with equal male and female ratios. Anxiety disorders are the most common mental, emotional, and behavioral problems to occur during childhood and adolescence. Not ADHD, okay? Anxiety is. However, as we discussed, that it is oftentimes misdiagnosed or overlooked. So how many of your experiences have involved a differential diagnosis of ADHD? So about 50% of you here today. And we're going to talk a little bit about the differentiation a little bit later. So the truth is that about 13 out of every 100 children and adolescents between the ages of 9 to 17 experience some kind of anxiety disorder. So that's a lot. That's a lot. So OCD symptoms in children and adolescents typically involve other family members and cause impaired functioning in the family system as a whole. In an attempt to reduce the child's anxiety and fear, family members tend to become servants to the child's compulsions and avoidances. How many of you here are slaves to your child's compulsive behaviors?
He wants us to be.
He wants you to be, and you refuse. That's perfect. Okay. Family members tend to accommodate the compulsions in order to avoid conflict and maintain peace. However, their accommodations only serve to reinforce the obsession and maintain the vicious OCD cycle. As you see over here, what happens is that the child will exhibit a lot of fear. However, children don't necessarily understand how to express the fears. Usually it comes across in the form of temper tantrums and angry outbursts. How many of you have experienced that? And you don't know how many times I get a child into my office and parents come in thinking that they need a parenting guide or behavior modification. The school thinks that the child needs behavior modification, or the child is coming in for ADHD, and we do the assessment and we evaluate the child, and it's actually because of an anxiety disorder and OCD. There is even more times when a child comes in for just a general anxiety disorder, and it's actually OCD after we do the evaluation. So what happens when the child is creating this temper tantrum or emotional meltdown? Well, it creates a lot of frustration within the family because it's hard to be able to calm the child down, and therefore there's conflict, right? And we all want to maintain peace. That is our goal. And most of us will try to maintain peace by becoming servants to your child's compulsive behaviors. Okay, Johnny, I'll open this door for you. Okay, Johnny, I'll get that for you. Yes, Johnny, you're not going to die. This is okay to do. How many times have you responded in that way? Okay, so you're very familiar with this. All right. Family members may be uncertain whether the rituals and reassurance seekings are part of the symptomology or only demands for attention and control. So, for example, a child may be exhibiting temper tantrums, maybe for attention, negative attention, maybe because they want something and they can't have it, and therefore they're exhibiting the temper tantrums. However, for the OCD child, it's because of the intense anxiety, the discomfort that they experience, and they don't know how to express that. So they express it in the way of temper tantrums because unlike adults, children have very limited experience with anxiety and discomfort. So they don't know how to express it. They don't know what it is that they're actually experiencing. Okay. Many family members may react angrily if they do not fully understand the child's inability to control the symptoms. However, negative reactions, rejections, and criticisms will only serve to increase the child's anxiety and worsen the OCD. It is very, very important to be supportive without enabling the child, without enabling the OCD symptom. And in the back of your handouts, there are a list of guidelines of what you can do, coping resources for yourself, that will also be revealed later on in the talk. So it's very important for family members to learn how to be supportive, okay? And in order to accomplish this, it's very important to psychoeducate family members and the patient about the vicious cycle of OCD. I always tell patients and family members that if you understand what OCD is and how it functions and the process of it, it's almost like a light that comes on in a tunnel. And you're able to see the path that you have to take to get to the end of that tunnel. Many times when we do the psychoeducation component, which I'm going to do now, it's almost like a light bulb turns on in their heads and they know exactly what they need to do to reduce their fears and to resist doing the compulsive behaviors and why we do exposures. How many of your children have engaged in exposures and response prevention? How many of them have been compliant? Okay, so much less, right? And usually it's because they don't understand. Why would you want me to go and confront my worst fears? Which is what OCD is, right? And when you do that without an understanding of why, it breeds a lot of resentment. Resentment for having the condition, resentment towards you as parents for making Johnny go out and touch toilets. Who in the world wants to touch toilets? Even those of us without OCD don't want to touch toilets, right? How many of you have seen Dr. Toland's OCD project show? Did you see the part when he licked the bottom of that lady's shoe? I was grossed out with that. Now imagine a person with contamination issues, and you're telling me to lick the bottom of a shoe? I would be so resentful if I didn't understand why. So now we're going to talk about why, okay? This is the vicious OCD cycle, and many of you have probably seen this diagram before. OCD starts with an obsession. An obsession is any thoughts, images, or impulses. It can just be a feeling of not being right, something not being right. And this feeling triggers discomfort. You can call it anxiety, nervousness, tension, whatever it is. However, it creates a lot of discomfort. And when I say discomfort, let me give you a graphic image of what I mean when a child experiences OCD, okay? Can you imagine being burned alive? Can you imagine being buried in a coffin alive? This is the level of discomfort that I'm talking about, of what OCD can create, okay? And none of us want to experience discomfort, especially in our society today where we're all about getting quick fixes. If you have a headache, what are you going to do? Go for the Tylenol, right? Go for the Advil. I want a quick fix to not experience discomfort. For the OCD child, we do compulsive behaviors. If I'm feeling dirty, I'm going to go wash. That's the logical thing. However, sometimes the compulsive behaviors are not so logical, such as tapping, right? How did that come about? Classical conditioning. So initially, I have a thought. It's creating a lot of anxiety. I'm tapping maybe because of nervousness. And then eventually, my anxiety goes away. Now, I'm going to think back, wait, what happened there? Oh, I was tapping. So tapping must work. So the next time when the thought comes back, what am I going to do? Let me see if the tapping works. And that is sometimes how compulsions get connected with those fears and the anxiety that it creates, okay? Even as illogical as it may be. The problem is, OCD is like an addiction. So tapping may work right now, sometime later, it's not going to work. I'm going to have to do something different. And the child with OCD is very, very creative and will come up with creative ways of tapping differently. Well, let me tap 10 times this time. Now we've got numbers involved in the compulsive behaviors. Do you see how we start building a web of compulsions connected with various fears? Okay. Now, the compulsions give us relief. I'm comfortable now. This is a problem. The problem, it's a problem because that thought will always come back. And when that thought comes back, because you got relief, it's just like taking the Tylenol when you have a headache. Are you going to go back for the Tylenol the next time around? Yes. Let's say you're out of Tylenol and you got Advil. You take the Advil, you have extreme headache, you take the Advil, Advil doesn't work. When the headache comes back, because it always does, are you going to go back for the Advil? Less likely, because it didn't work. This is exactly how OCD functions. If there is relief, then the compulsions will be stronger and stronger and stronger. So even though the compulsions serve to reduce anxiety initially, in the long run, it actually reinforces that whole cycle. Okay? This is the OCD triangle. And basically, we have 3 levels of functioning. We have our thoughts, we have our emotions, and we have our behaviors. Okay? Now, how many of you think that you can control your emotions, such as anxiety and anger and happiness, frustration? How many of you have control, 100% control over your emotions? I know I don't, okay? And the truth is, we don't have good control over our emotions. We have our defense mechanisms to avoid, escape, ignore. However, if I snap my finger and say, I want all of you to be ecstatic right now, you're going to have to think of some image or some experience to create that emotion, right? Guess what? It means that the emotion comes from a thought. So you have to first have a thought before you have an emotion. So now let's look at thoughts, the cognitive angle. How many of you think that we have good control over our thoughts? Yeah. And the classic experiment is, I want you to not think of the yellow duck. Don't think of the yellow duck. Don't think of the yellow duck. Now, don't think of the yellow duck in the blue pond. Don't think of the yellow duck in the blue pond. What happens? Do you have images of the blue pond and the yellow duck? Okay. So, thoughts, we do not have good control over either. And this is the reason why. You have 5 senses, okay? And from the time that you are born, when those 5 senses are developed, are they ever turning off? Do they ever turn off? No, not even in your sleep. All your 5 senses are always going to be on. And imagine all 5 of your senses are absorbing information from the environment, are absorbing stimuli. You can't turn them off. You may not be aware because you're just overstimulated by the brightness in this room and by hearing me talk and maybe the chilliness of the temperature in this room. However, unless you focus attention onto it, you may be experiencing things that you're not even aware of, okay? So if you have all of this stimuli entering and exiting your mind, you really don't have control over what thoughts you have. What we do have is called selective attention. So we choose to attend to one thought or another. That is the only control that we have. So when I say, don't think of the yellow duck, I just suggested for you to pay attention to that thing that you're not supposed to be thinking about. See how complicated that can get? Now let's do the opposite. I want you to do nothing but think of the yellow duck. Yellow duck, 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 yellow duck. How quickly does that yellow duck fade away? Pretty quickly, right? You can only think of that yellow duck for so long, and it's the same rationale because you have about 1 million different stimuli that enters and exits your mind at any given 60 seconds. So you can't really focus on any one thing for too long. This is the basis of exposure therapy, exposure and response prevention. Okay? The only thing that we can control are our behaviors. So if I say, Johnny, stick your arm out, he can stick his arm out, right? Johnny, don't think of the yellow duck. He's going to be thinking about the yellow duck. So that doesn't really work there. Okay, so behaviors, which means compulsions, are the only things that we have control over. I can choose to engage in this compulsive behavior or not. However, I cannot choose what type of obsessions come into my mind. Okay? So the behavior therapy guideline, this is the basis for exposure and response prevention, is that you cannot control your thoughts. You cannot control your feelings, so the anxiety and the discomfort. However, you can control your behaviors. And as you change those behaviors, those compulsions, your thoughts and feelings will also change through the process of habituation. How many of you remember the fight or flight response in your biology classes? This is the classic example. You walk out of your cave, and right in front of you sits a saber-toothed tiger. What happens? What is the fight or flight response? You run, or you fight, or you get eaten. Right? Okay. So you have two responses. You have to remember that the human body is a well-made machine equipped for survival. That is our goal, to survive. In order to survive, when you're faced with danger, two things must be done in order for you to survive. Either run or fight your threat. Okay? In order for that to occur, certain mechanisms in your body has to occur in order for you to engage in those actions. So, your heart rate increases. Anyone know why your heart rate increases? Absolutely. So you're pumping blood, right? You're pumping blood, and blood is circulating oxygen to all of your organs, especially your muscles. Your muscles cannot move without oxygen. Have you ever had a, you wake up and your arm is asleep? Your arm won't move. It's because it didn't get enough oxygen, okay? Your breathing intensifies. Why does that happen? What are you bringing in? Oxygen. Right? You're bringing oxygen into your lungs so that your heart can circulate it. Okay? Do you know that your pupils dilate? Your pupils dilate to bring in more light so that it can see more danger, to sharpen your vision. Because if there's one saber-toothed tiger, there might be another. Right? You never know. Okay? Your GI tract shuts down. Why does that happen?
More blood available for the brain.
Absolutely. You need the blood to be going to your muscles and your brain. So meaning that there is less in the core where metabolism occurs. So your GI tract shuts down. And that's a very, that's kind of very smart. Can you imagine running and all of a sudden, I gotta go use the bathroom? Can you imagine that? So your GI tract shuts down, okay? And you begin to sweat. Why do you sweat? Like any well-made machine, if your motors are running, it's going to produce a lot of heat, and heat has to come out in some form. So for the human body, it comes out in the form of sweat through your pores. Isn't that a well-made machine? So that you can either run or fight from the saber-toothed tiger. Now, how long do you think you can run or fight before your machine shuts down? In the face of real danger? Well, roughly about 60 to 90 minutes, depending on your health and so forth. However, at that state of real danger, your body can run, your motors can run for that long, 60 to 90 minutes. It may be the longest 60 to 90 minutes in your life. However, that is how well your body can function. So by the end of that 60 to 90 minutes, like any well-made machine, it's going to exhaust itself, and you need to recharge, okay? This is another principle behind exposure and response prevention. If you expose a child to their fears, rest assured that you will only experience that for so long before your motors run out, okay? Now what if, let's take that saber-toothed tiger example again. What if you come out of your cave, and instead of thinking, dangerous saber-toothed tiger, you think, oh, what a cute, cuddly kitty cat. What's going to happen? You'll become lunch or dinner, right? However, you have this, the point of this is who is the one to give it the meaning of cute, cuddly kitty cat versus, ooh, the saber-toothed tiger? We are, right? We're the one to give it that meaning and that value. And if we're the ones to do that, we are also the ones that can take that value away, to remove that value. And the truth is that over all of these years, we really don't need the fight-flight response that we used to, because there's less dangers in our world. Our world today consists of different type of dangers. Traffic, right? What am I going to get for dinner? I've got an exam tomorrow, I've got a cram. So our dangers today are different. They're not as big and threatening as they used to be. However, because our autonomic system hasn't really changed, we're still being aroused due to all of those little tiny insignificant dangers. The problem is, once your fight-flight response is triggered and you're hyper alert to danger, I call them the anxiety antennas, the danger antennas. Once those antennas go up and you're hyper alert, you're going to continue to seek out other dangers. Because if you're experiencing one danger, you're going to seek out other dangers that may be out there. And if you're looking for danger, will you find it? Yes, anything can be danger. You know, this light over here may fall at any time. I don't want to be sitting underneath of it. I feel sorry for this row of people who are sitting underneath in case we have another earthquake. It may fall and drop on your head. So if your worry antennas are up, you will find anything to be dangerous. Okay? So this is the process of habituation. In essence, the blue line over there is basically what any person with OCD experiences on a daily process. They get an obsessive thought. Their anxiety will raise. And then they do their compulsive behavior, anxiety goes down. Does that mean the thought will never come back? thought will always come back, just like don't think of the yellow dog. What happens? Thought comes back. Ooh, there's that thought again. What did I do last time for my anxiety to go down? I tapped. Well, let me tap again. Compulsive behavior. Anxiety goes down. And in a given day, they're basically riding waves after waves of anxiety. And what exposure and response prevention indicates is that we're not just going to let the thought come in, we're actually going to make the thought, trigger the thought, okay? However, we're going to trigger the thought, take control over it, and not engage in the compulsive behavior, not go for that Tylenol, okay? And over time, the longest 60 to 90 minutes in your life, your motors has to go into exhaustion. And guess what? The next time when that thought comes back, because we're actually going to make the thought come back, we're going to do the exact same thing. Do you think that it will take as long as 60 to 90 minutes the next time for your motors to run out? Probably not. Maybe 59 minutes. Okay? Do you think that your anxiety will be as high as it previously was? Probably not. Okay? And the reason being is because you're training your brain to understand that this isn't really dangerous. I don't need to engage in these behaviors. And the threat isn't really a threat. And my discomfort level will go away on its own. And you're retraining your brain to do that. There's so much research in the last 15 years about the neuroplasticity of the brain. And this is essentially what exposure and response prevention does. Okay? So the physiological effects of anxiety, basically it raises blood pressure and your heart rate. Okay? The problem is, because you're amped up, your body is amped up, and your GI tract is shut down, it causes all of these bodily complaints. So how many times have your child said, I can't go to school today, I feel like throwing up? Or I can't go to school today because my stomach hurts. Or they get called, or you get called into school to pick them up because they're feeling sick. Usually, they're not lying about it. Okay? Usually it's because it really is causing all of these symptoms. For children, because they, and even so for adults, they're going to have a hard time concentrating in school. Let me give you an example. Can you imagine your child missing? Let's say it's 12 hours. They've gone disappeared for 12 hours. Can you imagine what that feels like? Now let's up it up, and now it's 48 hours and they're missing. Where would your discomfort level be? Pretty high, right? So would you be able to participate in a group discussion? No. Would you maybe be jittery and walking around and pacing and perhaps even picking up the phone and calling people? Have you seen Johnny? Does that mean you are hyperactive? Would you be able to pay attention to me speaking here? No. Does that mean you're inattentive? In essence, of what I'm getting at is you would look like someone with ADHD. Doesn't mean you have ADHD. Okay? And this is almost always what happens at school. Little Johnny is being jittery, can't sit still. And the reason is because there's all this anxiety happening, and little Johnny may be jumping around in places. Little Johnny may not want to touch other students, may throw temper tantrums because the boy next to him stuck boogers next to him. And he's got contamination fears. Okay? Doesn't mean that he's got oppositional defiant disorder. No. Okay? So, these are two classic symptoms, oppositional symptoms and ADHD symptoms that children with anxiety and OCD typically get misdiagnosed with. I once had a child brought to me for behavior modification. He had anxiety, however, parents were about to take him to residential treatment. And let me tell you why. He refused to go to school every single morning and would say, "My stomach hurts, I'm going to throw up." And parents would say that every morning it was waking up to a nightmare. When he does make it to school, parents are always called in to pick him up because he is having throwing temper tantrums or having meltdowns at school, and the schools can't give him the attention that he needs. So parents get called in to pick him up. His anxiety would get so bad that he would shout things out such as, "I want to kill you. I want to shoot you in the head." The police was called one morning because he was found jumping on top of his parents' car, shouting out, "I hate you for making me go to school." Now, if we just look at the behaviors, that would seem oppositional defiant, right? However, this kid was just filled with fears, and his fears were about something bad happening to his parents when he's away, being alone, and being kidnapped. I believe someone down his street was kidnapped once, and from that point on, he had that stuck in his mind. Okay? When we first did our first exposure in my office, I had him walk to my receptionist desk, which was probably about 20 feet away. Do you know how long it took him to walk away from his parents to the receptionist desk, where he was still able to see his parents? He was still checking to make